Good day, everybody. I'm Richard Fink, workers' comp lawyer. This is the workers' comp podcast, Injured Workers Side. Today, we're very honored to have as our guest Dr. Michael Ford, who's been an orthopedic surgeon for decades. And Paul?
Hello, everyone. My name is Paul Taylor. I'm a licensed paralegal by Law Society of Ontario with a specialization in workers' compensation and human rights law. If you want to reach out to either one of us or be part of our podcast, like Dr. Ford today, you can contact us through the links below. Today's special is our guest, Dr. Ford.
So Dr. Ford and I go back to decades. My favorite story with Dr. Ford is one day I'm playing baseball and it feels like my knee is shot. Dr. Ford says, "Give me a week, I'll go into your knee and cut out the cartilage that tore." About 2 days later, I'm bicycling. And my spouse calls Dr. Ford up and says, "Please talk to him. He's just 2 days post-operation. Now he's bicycling around." Dr. Ford said, "Any exercise is good. Let him bicycle."
Yes.
So off I go. And what I would do at the office for my knee was I would take all my calls and do all my work while I'm on the floor doing exercise for my knee as I'm desperate to play baseball again. And about 2 weeks later, I could sort of limp around the bases.
Good.
So thank for that.
You're welcome.
My question today is results in one of the cases we've been dealing with at work. The worker's injury was climbing up 3 or 4 flights of stairs 2 or 3 times. The worker was a personal care worker, so they had to go up and down stairs at the residence where they were working at, and they developed back pain. And their claim was eventually allowed for disc protrusion at the L5S1 level, an annular tear of the disc, and left leg radicular symptoms. And my question always is, what is going on here?
This is not an uncommon scenario. I mean, a lot of people claim that an association is causal, when in fact it isn't. And this goes back historically, of course. Historically, we've made all sorts of mistakes in the medical realm and assigning causal associations, and subsequently, with good research, we've recognized that in fact that's not the case. And unfortunately, in the past, when we're assigning associations that aren't causal, it leads to inappropriate treatment. But over the last 20 years, especially, we've had some really, really good research that has taught us that, in fact, that the injury model of back pain is really not accurate and it's not evidence-based. Specifically with respect to disc herniations, for instance, there's a good study to show that less than 1.3% of disc herniations can be in any way even marginally attributed to an episode of trauma. And the authors of that paper admitted that they weren't stringent with respect to carefully looking at the temporal association between an apparent injurious event and the onset of symptoms that we'd associate with a disc herniation. Um, a great paper by Hamilton Hall in the past with Greg McIntosh at the Canadian Back Institute looked at over 11,000 patients. And they found that in the group where there are no compensation issues, 67% could not even think of an initiator. And the other 23% or 33% weren't too sure. They couldn't describe really a good initiator. In the compensation group, 9.8% could not describe an initiator, which is interesting given that they're in a situation where if you can't describe a specific work event that initiated the onset of your symptoms, you don't get compensated. So these people were being either incredibly honest or they were being incredibly dumb. Um, and then there's a lot of other studies too. For instance, there was a great study to look at, well, does a minor injury result in low back illness? And there was no evidence that was the case. In 3 series of multiple trauma patients who have been involved in car accidents where they've fractured their pelvis or broken their femurs, that they've had bad abdominal injuries, in the groups that didn't actually have any spinal fractures, none of them complained of any chronic neck or back pain. And then when you take a look at the studies, for instance, that involving car accidents in countries where you can't get money because of your, hit from behind car accident, none of these patients complained of chronic neck pain or back pain. So the injury model, for the most part, has been debunked. We recognize that this is a degenerative etiology problem, and it's like I said earlier, it doesn't make any sense to claim, for instance, that you've gotten gray hair because you wear a hat too much, or you've gotten wrinkles because you didn't use the appropriate skin creams or whatever, or because you're exposed to a lot of wind. I mean, we know that gray hair and wrinkles are an age-related problem, and that degenerative etiology problems are the main cause of back pain. And we also recognize that, so-called spinal degeneration, which is a bad term. It's degeneration implies something ominous, but we know that these changes start occurring in your late teens and early 20s.
So, Paul, did you start out with a back claim?
Interestingly enough, what I've observed with myself and with clients is that a lot of the times you have to look at the work that they're doing, and that's usually like if you look at the WSIB's workplace injury form, they never ask, what kind of work do you do? And I mean, somebody that does, like, say, light work, office work, and that, and they suffer a back injury, you'd be like, hmm. But then somebody that's lifting, say, 20, 30,000 pounds manually every day, hand unloading, and then they have a sudden injury afterwards, you'd be like, oh. And I think that it's actually two injuries in one. And I think that's what happened with me because I did do a lot of physical work every day, unloading. And then when I had a load fall on me, there was a sudden injury. So where they would say, well, a sudden injury, back injury, you should be fine in a couple of weeks. What complicated things was they didn't look at the actual overall work environment. Like earlier, you were talking about a PSW. Right away, that flags in my mind to say, I wonder if they lifted the patients or maneuvered them, which is what I would classify as heavy physical repetitive work, which drains on the body. I read a paper once from New Zealand about degeneration, like you're talking about, and like there's the normal wear and tear on the body, and that we shouldn't see for a long time, and that's fine. But what they're talking about is where you have excessive wear from work, from that repetitive heavy lifting. And I'm just wondering what your thoughts are on that.
But again, it's interesting because the research has shown that it's actually a very weak association between back pain and the nature of your occupation. For instance, they've shown that there's no dose related. One would think that the heavier work that you would do, there would be a greater incidence of low back problems. But in fact, that's not the case. And
Really?
when you take a look at across the board at different occupations, the incidence of back pain isn't that much different between the sedentary office worker and the person who's doing heavy manual labor. And as I said, there is no dose response relationship. If there was truly a causal association, then we should see a dose response relationship. And there isn't. It's just not there. For a while, they were looking at, because that was the case, they were thinking, okay, perhaps there's another sort of mediator. And they were looking at vibration, whole body vibration. And that sort of seemed to have promise for a little while, but then subsequent additional studies said, no, again, if there's a causal association, it's incredibly weak. And so there's a lot of misinformation out there that is being nicely cleaned up and corrected with better evidence and better research. Because when you take a look at some of the older studies with respect to work and low back pain, a lot of those studies were very flawed in their methodology. They didn't have the data set, the size of the cohort that they were examining that warranted any specific conclusions. And so with better research, more stringent research being done by better trained epidemiologists, we're seeing in fact that the injury model, as I said earlier, is really not applicable.
So you're saying somebody that does heavy repetitive work every day that shouldn't be doing that kind of lifting wouldn't experience an injury?
Correct. We're finding out more and more now that extrinsic factors, obviously the things that we know about like obesity and smoking, have a role to play. But more and more, we're seeing the important role that genetics has as well. A couple of really good identical twin studies, and some of those two papers were amazing. I mean, they showed MRIs of individuals who were identical twins, so they got the same genes, but they were disparate with respect to their occupations. One would be an engineer who's sitting at a drafting table, and the other one would be a painter or a manual laborer, but their MRIs were virtually identical too. You look at the pictures and you think, oh, that's a mistake. They must have just accidentally copied the MRI. But no, they're exactly the same as to which discs were black discs, which levels had osteophytes, which levels had disc protrusions, for instance. It was really incredible to see.
So in the case I was talking about, we have a pain doctor uh, that does pain medicine and occupational diagnosis, and he stated the disc protrusion and annular tear symptoms were connected with the work activity.
And that's wrong. Because, in fact, MRI studies of asymptomatic individuals show a high prevalence of disc protrusions and annular tears. There's no relationship with respect to symptomatology. The MRI is incredibly sensitive. It shows us everything, but it's not very specific. Not all of the things that we see on an MRI are, in fact, symptomatic. And in fact, we now know there's only really two things on an MRI that can be reasonably correlated with symptoms. And that's modic changes, and these are the end plate changes that occur in the bone, and a true disc herniation that's actually significantly compressive. It's compressing a nerve root. Those are the only two things. Everything else, like facet arthropathy or disc protrusions or annular tears, if you look at those, it's highly unlikely that you would be able to predict what that patient's symptoms are. And we're starting to see that now, not just in the spine, but we're seeing that MRIs of knees, MRIs of shoulders, and the list goes on and on. That for years, the MRI has been misinterpreted, and we haven't realized that it shows us a lot, but these things are not necessarily symptomatic. And so that's the reason why an MRI is actually very non-specific. Sensitive, yes, but non-specific.
The people who let's say you have the tear of the disc and you operate, what are you doing in the operation?
Well, we don't operate on tears. We'll only operate on a disc if there's in fact a large disc herniation, which is compressing a nerve root. And there has to be a really good match between the imaging study and the patient's clinical presentation. I mean, a disc herniation is only considered to be clinically relevant if the patient is presenting with leg dominant symptoms, and then they have the physical findings that we associate with that, such as irritative findings, which is typically a limitation of a straight leg raise, and then they may or may not have evidence of a neurological deficit like motor weakness and or sensory loss.
So you're cutting the piece of the disc out that's protruding?
Well, basically, it's kind of like and I try to explain to people that the disc has tough outer fibers called the annulus, and the central part of the disc is called the nucleus. And contrary to what the physios will say, it's not a fluid. It is actually stuff that looks more like crab meat. And with degenerative change, you can get tears in the outer fibers, and some of this crab meat can escape and produce a big pimple on the. And typically, the weakest part of the annulus is the posterior annulus. So this pimple will go backwards, and unfortunately, that's where all the nerves are. It's actually like an error in design, uh, which a lot of the religious people won't be happy with. It's not intelligent design at all. Um, and so this stuff will go backwards, and that's where the nerves are and compress a nerve. And so that's that will produce leg pain typically if the disc herniation is in the low back, and it'll produce arm pain if the disc herniation is in the neck. And so what we do is we go and we remove that piece of disc tissue. Now, a lot of people will get better without any surgery, and that's because that crab meat will dry up and shrink. As explained to people, it's a rather another disgusting food analogy. I mean, if you had a can of crab meat and you left it on the counter for a couple of weeks, you'd come back and be a shriveled little ball because it desiccates, it dries out, because the nucleus actually does have a high water content, and we see that in healthy discs on an MRI. On the T2 weighted images, the discs look white in the center because the nucleus has a high water content. On an MRI, water looks white, and on healthy discs, they're called black discs because they become desiccated, because they become dried out, just like the rest of the body becomes dried out as you get a little bit older. And of course, that's the reason why you see wrinkles. Of course, I mean it's a little bit more complex than that, but that's a feature of age-related changes, which I said unfortunately starts a lot sooner than people think. It's typically in our late teens, early 20s. The peak incidence, for instance, of disc herniation is in individuals between the ages of 20 to 40.
When you remove the protruding part of the disc, I assume the expectation is that the radiation into the leg would cease.
Almost immediately, people wake up in the recovery room and they go, "Oh, thank God that pain is gone." It's a very reliable procedure. If you're very selective, close to 100% of people will experience relief after that surgery, which is now a minor surgical procedure. It's done as an outpatient and is typically done through a tiny little incision, or of course, some people are doing it minimally invasively through a scope, although there's really no significant difference between the two approaches. And so it is virtually immediate. But otherwise, in the papers that have been published in carefully selected people, over 90% do very well with very minimal risk.
And the 10% who fail, which of course become my clients, i.e.,
Mm.
they have difficulty walking and need all kinds of work restrictions.
Yeah. When you go back and look at the failures, there's typically a list of reasons for the failure. Now, the first one, of course, is the wrong diagnosis. That this was an individual who had a protrusion that wasn't clinically significant, and they're presenting with back dominant pain rather than leg dominant pain. The other one, of course, unfortunately, is wrong level surgery. If that happens, but does happen still, then obviously the patient will not get better. But then in those patients, typically that fail, they have what are called yellow flags, and the biggest yellow flag is any compensation issue. And the other one is if they've been on narcotics, high dose narcotics previously. If they've got a lot of their medical comorbidities, for instance, if they're a diabetic, then the numbers are slightly reduced. If they're a heavy smoker, again, if they're morbidly obese. So there's a bunch of other reasons why you may not have the expected outcome.
And in your practice as a surgeon, when you were still operating, did you screen for sort of personality, psychological disorders before you decided to open up the person?
No, typically we don't, but a lot of the papers have done that. For instance, they know that those individuals have been screened. For instance, those have been subjected to an MMPI-2, uh, that it can be predictive of a poorer outcome. And as I said, there's no question that compensation issues are predictive of a poorer outcome. And that's even in those procedures that we know are invariably associated with an excellent result. Not just microdiscectomies, but for instance, total knee arthroplasty or total hip arthroplasty. Again, 90+% of those patients are incredibly happy. But when you take a look at the compensation population, that number drops to like 50, 60%.
So, Paul, there's not much wrong with you, really.
Somehow
No,
I
that's
find that hard to believe.
I know it's hard to believe, and that's the problem.
Well,
Is
because I wasn't obese at the time, I was young at the time, and I
Yes.
didn't smoke at the time.
How young were you?
I was 28.
Okay, I
And
told you that it
and
starts in your
and
late teens, early 20s.
and like I said, it wasn't just the heavy lifting, it was load that had fallen on me.
I know.
So,
But again, it didn't cause any fractures, I'm assuming.
well, I don't know They never did any X-rays or MRIs or anything.
You must have had some imaging studies afterwards.
Yeah, about a year later.
Okay. And still, if there was evidence of a fracture, it would still be there.
Yeah.
Did you
No, there wasn't.
were you operated on, Paul?
No, no,
Okay.
no. This is one of the problems that I think is being missed is the forced return to work program, where the board will look and say this type of injury should be better in a couple of weeks, and they force you back to work, even if your doctor's saying you shouldn't. And that's a
Well,
huge factor for recovery.
yeah, that's because again you had the wrong diagnosis. For instance, if you're given the diagnosis of sprain/strain, which is what we see most commonly, then
Hmm.
yes, that's something that typically does resolve in a short period of time. But in fact, that diagnosis is improperly used in the majority of cases. A sprain/strain is like if you sprain your ankle, if it, and it's how many people actually have a sprain or strain of their biceps? That's incredibly rare. So to claim that, for instance, uh, a slip and fall or whatever results in a sprain of your paraspinal muscles is not appropriate either because they've done acute MRI studies. And if you sprain your ankle, an MRI it looks like a bomb has gone off in your ankle. I mean, it's really impressive. And if you do an MRI on someone who has an acute episode of low back pain, most of the time you see absolutely nothing because we typically don't know exactly where the pain generator is. And it may be just, a little degeneration in the outer annulus, which is innervated. It is innervated, especially where it's attached to the bone. And the end plate itself is innervated. It has a nerve supply and it's pain sensitive. And anybody who's had a discogram will tell you it's incredibly painful, even if you just inject fluid under pressure into a disc. It can be very, very painful. But the thing is, if you believe in the injury model, then you can't explain the spontaneous onset of back pain. You cannot explain those individuals who are in sedentary jobs who are literally crippled by their back pain. You can't explain, for instance, the 40, 50-year-old woman can barely walk because they have a degenerative spondylolisthesis. And so you have to have a theory or hypothesis that explains, the majority of cases that you're seeing. And the injury model doesn't allow you to do that, unfortunately. And I have no doubt, for instance, there were a bunch of guys that were doing the same job as you and they were fine, you know.
No.
And there's
No,
also
actually,
well,
there
don't
was a very high injury
well
rate at my
well
workplace.
okay, don't forget that the prevalence or the incidence of low back pain is close to 80% of individuals will experience significant low back pain that they seek the services of a healthcare provider over the course of their
But they
lifetime.
weren't, they weren't, let me be clear, in the time that when I was injured, and even my claim, it wasn't a strain, like it wasn't like oh, I pulled my back muscle. Every one of the injuries were sudden accidents, meaning they were usually hit with something. Like the guy that replaced me,
Mhm.
he was permanently disabled, to my understanding, paralyzed, because a load of antifreeze, a case of antifreeze, hit him in the back. You know,
Okay, paralysis only occurs if you have a
I don't know.
fracture and
That's
or
what I was told.
dislocation. Yeah, that's a totally different issue, Paul.
But
That's
you're
not what
you're
we're
talking
talking about
about
here.
a case that's about 90 pounds fell and hit him in the back. I
Yeah,
don't
the only way you can
know.
be paralyzed is if you have a
Yeah.
fracture and or dislocation, which is not what you had.
Well, no, that's not me. I'm talking about the other guy. I'm
Yeah,
talking
I know,
about the
and that's fine.
workplace.
There's no question that injury can cause serious
Yeah.
back issues, but invariably it's a fracture and or dislocation.
Yeah. That was him. So what I'm describing is the workplace and saying
Yeah,
that
that's very
in
different.
virtually every case, there was no strains, as you would call them, where, you bent over and all of a sudden you had pain. In every
Mhm.
one of them, they were sudden accidents where they were hit with something. So they would
Okay.
be, I guess you'd call them contusions or whatever. In
Yeah.
fact, initial diagnosis was a contusion.
Mhm.
And then over time, the board told him to say it was a strain. See, that's one of the problems you'll find in my experience in dealing with WSIB is that they are too tightly woven in the medical treatment and diagnosis. And it really concerns me because one, the worker isn't getting the proper treatment and care. And a lot of the times they're being shoved off and saying, well, it's just all in your head and you're faking. And they may have genuine serious injuries. The other problem is they're not getting the proper coverage. Whereas with if it was, say, a slip and fall claim or a car accident or something else, they're being treated fairly. And I've talked to many injured workers where it's almost like when they want to go to get treatment, they don't want to say it's a work injury anymore. They want to say it's, oh, I just hurt myself at home because of that fear of the stigma with the health professionals who then tell me when they call the WSIB, they're berated and treated horribly. Because the case managers are on the case, get them back to work, get them back to work. They don't care about their recovery. Because let me ask you, if a case manager's wrong when he's telling the doctor that the worker's fine or whatever, the case manager doesn't go to jail. They don't get sued or anything, right? So they can push that envelope, and they have been for many years. And this is the concern I have. I have no doubt that if my injury, and I state this on the record, is that if I had been treated fairly and properly in the recovery process, I would have fully recovered. But the board got in there and involved itself and just totally destroyed the recovery process. In fact, there's actually memos in my file where they're saying that this needs to be, handled more quickly and properly. And I hear this from injured workers every day that now under the new law, well, from 1998 on, if you don't cooperate in whatever they want you to, they suspend your health care. Any person would go, that's insane. That's their system.
So let us close. We'll give the final word to Dr. Ford after hearing Paul talk about the immorality of the WSIB.
So what you're talking about there, Paul, is a disconnect between the evidence, the things that I've talked about that we know for sure are true, and the social injustice that's associated with the WSIB, which is, a logistical problem. And there's also a big problem with respect to what we call bench to bedside, where the evidence is out there, but unfortunately, a lot of practitioners out there aren't familiar with the evidence. And not just the practitioners, but also, for instance, the lay people working at the board. And as you know, case managers typically are lay people.
So
And I've
I
had,
wouldn't blame the case managers. I think it comes from the top.
well, it's the same thing. They are lay people as well. They're
Yeah.
not necessarily, and it is a very difficult problem because there's no question, and you have to understand that there's no question that there are people that have terrible back pain and they can't work. And the problem is not just, it's organic or structural. It's not because they've had a serious injury and have serious pathology. You weren't just a back. These people are not just a spine. These are people. And the problem is not just organic, it's a psychosocioeconomic. Okay. And that unfortunately the system can promote and does promote disability. As you know, if you can't prove that you're disabled, you don't get paid. Well, unfortunately, you are stuck between a rock and a hard place. And the problem is that unfortunately, we don't have good treatments for mechanical low back pain of degenerative etiology. There's very little weak evidence that all the things that we're doing, like physio, chiropractic, all the passive modalities, are of any benefit whatsoever. That's the biggest problem, is that we don't have good treatments.
Well, on that unhappy note, I'd like to thank Dr. Ford for attending today
You're welcome.
and hope to see everybody next week.
All right.
Take care.
I
All right.
know.
Okay. Take care.